Thank you, Jasmine, for the kind introduction. So my job is easier than many, I guess. I'm giving the overview of PSC, clinical presentation, diagnosis, and management, kind of a brief landscape. I know it's a big talk. It could take hours, but we'll at least get to it. So I'm going to start with a case that I saw when I think initially started this program. So it was a 27-year-old patient of mine now who has no other past medical history, has been having itching for a few months without a clear cause. So he finally went to his primary care doctor, who ended up doing labs. His liver enzymes were significantly abnormal, as you can see. The alkaline phosphatase, which is, as you all know, the enzyme that's often elevated in PSC, was high. His AST and ALT were also elevated. So, the primary care doctor did ultrasound appropriately, and per report, it was thought to be normal. He was referred to a gastroenterologist, where they did MRCP appropriately because of the pattern of elevation in the liver biochemistry, which was also normal. So the GI doctor ended up, this is somewhere in the Central Valley, ended up doing a liver biopsy, which is great. Unfortunately, the liver biopsy the type of inflammation they saw was not specific to anything. But what was interesting was he has a stage 3 scarring, 4 being cirrhosis. So the patient actually has a significant amount of scar built up in the tissue in his liver. He was at stage 3. So the primary care doctor ended up starting prednisone at a high dose, which was like 80 milligrams a day, and did not refer him to hepatology for over 6 months. The patient actually had complications of prednisone. The sugar was high, he was gaining weight and not feeling well. So finally, he was referred to our clinic. Usually when we get a lot of referrals from outside, and we have to get the initial medical records, imaging studies, and review all of them. Here that is the practice in hepatology in general before we do more testing. Actually, his MRCP was not normal. It was read to be normal, but when we read it here, he did have stricturing in the bile duct, suggesting likely PSC type of changes, and his spleen was enlarged. So that goes along with having scar tissue buildup and portal hypertension, enlargement of the spleen, indicating that this disease has been going on for some time, and this young patient at age 23 has advanced liver disease. So we did additional labs based on the pattern of the liver enzyme elevation. I needed to rule out autoimmune hepatitis, which he did not have. Just because, again, the liver enzymes were significantly elevated, the AST and ALT. This was about a year down the road. We did a repeat liver biopsy showing features that could be seen in bile duct obstruction, but no autoimmune hepatitis. So we did ERCP because the labs were elevated. He was having itching. He had obstruction of one of the bile duct, needed dilation. And the liver enzymes started improving, and he was then diagnosed with PSC. So it took, this is a 2-year course of just figuring out what is going on with a patient who actually had significant liver disease. I still follow him. He's actually doing fine. This is 10 years ago so far. So what is PSC? So PSC is a chronic cholestatic liver disease. When we say cholestatic, that's impaired bile flow, right? That leads to chronic inflammation. The inflammation leads to fibrosis and scarring, and over time of the bile duct inside and also outside of the liver, intra and extrahepatic bile duct, leading to cirrhosis and portal hypertension. Mean time from diagnosis to transplant, I think this has gotten a little bit higher, 15 to 20, Chris, would you say? It's a little bit higher than 14, 15. I think we're diagnosing them maybe a little bit early with increased awareness now. But PSC was described in 1924. We still have a lot about PSC is not unknown, particularly the detailed or isolated one specific cause of PSC. It seems multifactorial, and we still don't have a proven effective medical therapy except liver transplant in a setting of end-stage liver disease and other indications. So what is the epidemiology of PSC? It's more common in men than women, usually diagnosed in our 30s to 40s age range. About 75% plus are affected by inflammatory bowel disease, mostly ulcerative colitis, compared to if you look at patients with inflammatory bowel disease, vice versa, about 5% may have PSC. But if you're thinking about PSC, you need to make sure that you rule out inflammatory bowel disease. And I will go over the recommended workup. So annual incidence, it ranged between 0.9 to 1.3. A higher prevalence has been reported in patients from Northern European descent. A study that was done here in NorCal by Dr. Bolas and colleagues showed 0.4 per 100,000 person year. We definitely need more data. We need to include more patients and understand PSC more. I was just talking about the fact that I've been engaged a bit more in Africa, and in South Africa, about 40% of their liver transplants are for patients with PSC, versus here it's like maybe 5 to 10%, not even 10% in the US. So we still have to make more bridges, more connection, and understand this disease more. So signs and symptoms, some patients are completely asymptomatic, but the common symptoms include fatigue, pruritus, abdominal pain. I think we have a dedicated section today going over symptoms in PSC. Laboratory features, mostly alkaline phosphatase is elevated, but I have seen some patients with PSCs actually have significant disease on MRI, but have normal alkaline phosphatase. That is often elevated. AST and ALT are mildly elevated. Bilirubin can be elevated, thus often in a setting of bile duct obstruction or maybe advanced liver disease. IgG4 can be elevated in PSC without having a disease called IgG4-related disease, which I will review briefly. But I think the key thing in PSC is the liver enzymes can fluctuate over time. And that makes it difficult, right, to use alkaline phosphatase, for example, one marker that will tell us the disease state or progression, because there's a lot of fluctuation over time, which makes it difficult to use them as a marker of disease. In terms of antibodies, there isn't any really one specific antibody to diagnose PSC. An antibody called ANCA tends to be elevated, but that's about 60% of the time, often in patients with ulcerative colitis. So radiologically, on imaging studies, PSC often is diagnosed on cholangiography, which is imaging of the bile duct, either with MRCP or ERCP. ERCP is invasive. MRCP is, has a good quality and is often used as an imaging modality to diagnose PSC, and ERCP is often used to intervene on any obstruction, etc., blockage when we're concerned about cancer. But MRCP is a diagnostic modality used, and it shows segmental stricturing and dilation, creating that beaded appearance of the bile duct on imaging studies. Most patients do have involvement of intra and extrahepatic bile duct. Liver biopsy is often not helpful, like that was the case on my patient. It didn't really diagnose the PSC. The MRCP was a study that was able to identify the diagnoses. But liver biopsy can be used when we want to rule out, other comorbid conditions such as autoimmune hepatitis when the AST and the ALT are elevated, like that was the case for my patient. So if you are lucky, and if you did a liver biopsy, the finding that suggests that it could be PSC is this scarring around the bile duct, which we call onion skinning, but that's only present in about 15% of patients with PSC. So what is the diagnostic criteria? So we have to have a liver enzyme elevation and cholestatic pattern, which is, where the alkaline phosphatase is elevated often, and classic findings on MRI or ERCP, mostly MRI, because ERCP is not used as a first imaging modality. And we definitely need to rule out other causes of cholangitis, sclerosing cholangitis. There is quite a list, which I'm not going to put that up here today, but you have to rule out other reasons. There are, however, some patients that actually have clinical features of PSC in every way, except you don't see those strictures on MRCP, and those are our patients with small duct PSC. It's often difficult to make the diagnosis of small duct PSC. You need to rule out all other reasons, but they tend to have the clinical feature, but don't have the stricturing visualized on MRCP. So we talked about this small duct PSC variant. It does affect about 6 to 16% of patients with PSC. That group of patients, they do have a slower clinical progression to cirrhosis and lower rates of developing cholangiocarcinoma or needing liver transplant. So they do have a better prognosis overall. But over time, some of our patients with a small duct PSC can actually convert into large duct PSC. So you have to continue monitoring them with MRCP. There is an entity called PSC with autoimmune hepatitis overlap syndrome that's affecting about 10% of the population. Imaging findings of PSC added with liver biopsy and serologic marker indicating autoimmune hepatitis. That group of patients may need, in addition to possibly using URSO, immunosuppressives, because the combination disease can put them at the risk of faster progression to cirrhosis or liver failure. So they may need immunosuppression. There is an entity called IgG4-related cholangiopathy. This mimics PSC, except that patients with IgG4 cholangiopathy, they do respond to steroid. Their IgG4 is often elevated, blood, and also on biopsies. And the strictures that you see on MRCP or ERCP do improve with steroid. So this is completely different from PSC. They also don't have comorbid inflammatory bowel disease. So that's like if you're suspecting about PSC, you need to make sure that the patients get colonoscopy to rule out colitis. The IgG4 patient cohort doesn't. Let's see. So medical management, we currently don't have, as we all know, no approved medical therapy, but there's a lot going on, right, in terms of drug development for PSC, which we'll be reviewing today. Ursodeoxycholic acid is often used. It can improve liver biochemistry. We don't have a good data suggesting that it could improve survival, but there is some data that indicates that if your liver enzymes improve on URSO compared to the group that actually did not improve on URSO, the group that improved their liver enzymes, they tend to have a better prognosis overall. So in general, I think the liver or GI community is open and using it. I think I use it almost all the time on my patients if they can tolerate URSO. Liver transplant is available for, like I said earlier, for patients that actually developed end-stage liver disease with liver failure, and particularly in PSC, recurrent cholangitis. There's a mild exception point that is often granted for our patients to get priority liver transplant. And early stage cholangiocarcinoma, often hilar, but there is a newer now protocol for small intrahepatic cholangiocarcinomas that are less than 3 centimeters. We have that protocol here at CPMC. Dr. Merriman will be reviewing that today. Recurrent PSC after transplant is about 20% at 5 years, 5 to 10 years range. So we have to monitor for recurrent PSC after liver transplant as well. But like I said, there's a lot of emerging clinical trials trying to find cure for PSC, which we will review today. The unmet need that has been the limiting factor is, again, not having a good marker that actually can measure how drugs are working or how that could predict the prognosis in our patients. And there's a lot of research looking at that as well. So overall, in the management landscape of PSC, what do we need to do? You need to make sure that you get colonoscopy. Usually colonoscopy with ileoscopy, meaning getting into the small bowel with random biopsy, especially initially to rule out ulcerative colitis or Crohn's, is done at diagnosis. In the new guideline that Dr. Bullis wrote now says you should repeat that every 5 years if you don't have IBD at that initial colonoscopy, or if patients actually develop symptoms like diarrhea or blood in the stool, it should be repeated. There is increased risk of colon cancer with PSC patients that have colitis, about 4.8-fold increase. So there needs to be a surveillance colonoscopy, ideally every year, but it's every 1 to 2 years. There's a risk of cholangiocarcinoma, often diagnosed in earlier stage of their presentation. We have a dedicated section on surveillance for cholangiocarcinoma and advances, and there is increased risk of gallbladder cancer. We have to check fat-soluble vitamin deficiencies aggressively. Bone density scan, there is risk of osteoporosis, so we have to make sure that our patients are getting DEXA scan. Liver enzymes, in terms of how to the frequency of monitoring really depends on the underlying liver function. You know, it could be every 6 months or every 3 months, sometimes yearly in some of my patients, but I do tend to get screening cholangiocarcinoma every 6 months. So I think I'm running out of time, I was told, but I think it's good to compare PSC with PBC. I think some people get that mixed up. Can I have 1 minute on that, briefly? So PBC it does affect the small intrahepatic bile duct versus PSC is a larger. As we know, PBC affects mostly women, PSC mostly men. Age of diagnosis, PSC around 30s to 40s, PBC maybe in 50s. Diagnostically, anti-mitochondrial antibodies positive in over 90% of patients with PBC. That's not the case for PSC. We need MRCP. In PBC, we have treatments that can improve survival. We have 2 strong agents that are recently approved, but that's not the case for PSC. There is a lot of autoimmunity in PBC patients, like other comorbid autoimmune conditions with PSC. There is the risk of cancer, inflammatory bowel disease, and some degree of autoimmunity. They both share this cholestatic liver disease, symptoms of pruritus and fatigue, and as they end progressing into liver failure. So they're different, but they have some similarities. I will end here. Thank you.